Hello and welcome everyone to another virtual program by the Macular Degeneration Association. My name is Dustin. I'm the Communications Director for the Macular Degeneration Association, and we are happy to welcome you to today's program. We'd also like to thank our wonderful sponsors, Regeneron, Apellis, Sun Pharma, AbbVie, MacuHealth, and Notel Vision for their support of these programs. And of course, people just like you, because the Macular Degeneration Association is a 501c3 nonprofit. We are supported completely by donations from people just like you. So if you find the information today helpful and you'd like to make a donation, please see us on our website at macularhope.org. That's macularhope.org. Today, we have a wonderful program called Flashes and Floaters. Was that a bug that just flew into my eye? It's a little bit more fun for you. That's going to be brought to us by Dr. Leo Sims. But first, I do want to ask that if you have any questions at all throughout the program, to please put them in the Q&A box of the bottom of your screen. Do not raise your hand. Do not put anything into chat. Those will not be answered. And we ask to have you put in any questions as soon as you think of them. Just go ahead and put them onto the Q&A section. And at the end of the program, Dr. Sims will go ahead and answer those questions for you. So, without further ado, I'd like to introduce Dr. Sims. He studied at the Pennsylvania College of Optometry and completed his residency at the Eye Institute of Pennsylvania College of Optometry. He currently holds an appointment as Professor Emeritus of Optometry and Vision Science at the University of Alabama at Birmingham. He is a fellow of the AAO. Dr. Sims is a founding member of the Optometric Glaucoma Society, where he has served as a secretary and on the executive committee, and a founding fellow of the Optometric Retina Society.
Well, thank you very much, Dustin. It's my pleasure to be here on behalf of the Macular Degeneration Association. I'd like to welcome the audience here to talk about a topic that's pretty near and dear to my heart, which is floating spots, not so much flashers, but we're going to talk about both of those because this is a pretty significant topic. And those of you who are in attendance here are probably here because you experience either flashes, floaters, or both, or maybe it's a situation where you are old enough to remember that on this day in 1958, Chevrolet introduced the Camaro, the El Camino. So it's a problem that happens to older people typically, but my floaters began much earlier in life, and we're going to get to that as we talk about the causes of floaters and what some of the consequences might be and why it's important to address exactly what's going on. Obligatory financial disclosures. But I thought I'd start out with a little levity here. And this is a cartoon that I found very apropos. The gentleman here says, I guess I'm officially, quote, old. I just spent 10 minutes chasing an eye floater with my fly swatter. And I can't tell you how many times that I have tried to grab one of my floaters out of the air or step on it on the floor or seen something and think it's a bug or a mosquito or something in my vision. So those of you who experience this probably have somewhat similar experiences, and we could probably add to that list of what those particular visual phenomena might be. So let me talk about my personal experience. Like I said, I've experienced floaters for a number of years, and I was driving one day. I used to live in Birmingham, Alabama, and I was driving from Birmingham to Atlanta, and I saw this cloud formation. And I said to myself, golly, that's very much like some of the floaters that I see. So when you look at those clouds there, maybe that's the kind of floater that you experience or the pattern of floaters that you see, but they can come in many shapes and sizes. And a few years later, and I remember this day and time very, very specifically, that I saw this circular floater appear in my right eye. I was in my office building. I was on the fifth floor. I was facing a very brightly lighted western facing wall in the afternoon. And this circular floater appeared quite suddenly and very randomly. And what that represents, and we'll talk about the anatomy here, is when the vitreous separates or detaches from the back of the eye around the optic nerve. So our menu today here is going to address the causes of vitreous floaters, some of the concerns that patients may have, and then the consequences. And we'll talk about this in the context of mostly posterior vitreous detachment. So the biggest cause of a floater or flashing lights appearing in your vision is in fact going to be secondary to something called posterior vitreous de detachment. So let's talk a little bit about anatomy. Now, if we were to cut a section through your eyeball, like you would cut an orange in half or an apple or something like that, this is what we would see. So let me point out some landmarks here. This is the cornea. This is very clear, unless there are opacities secondary to infection or inflammation. And then the colored part, of course, is the iris. Hole in the center is the pupil. And then behind that is the lens. And just to put things into perspective, your eye is about the size of a ping pong ball. And this lens here, which gets cloudy with age, is about the size and shape of an M&M candy. Now, if you've had cataract surgery, what the procedure involves is essentially breaking the shell of that M&M candy and sucking out the chocolate and replacing it with an intraocular lens. But the majority of the eye is filled with the vitreous. And I like to describe it to patients as clear jello in a clear plastic bag. And that's what it is typically throughout life, unless there are aging changes or, to a lesser extent, inflammatory or infectious conditions or trauma that produce these little floating spots, these little threads in the vision or in the visual axis, which cast a shadow onto the retina. Now, the retina is the lining of the eye, and that's essentially the seeing part. This is often compared to the film in a camera. But these can, like I said before, resemble any number of shapes. They can be squiggly lines, they can look like a cobweb, or they might look like a bug, as our title suggested. And because this vitreous is a gel, as you move your eyes around or as you make eye movements, whether it's during reading or during driving, looking at a billboard and then back to the road, for example, they're going to move with your eye, and then they're going to come back and maybe settle down and maybe not be quite as much of a problem as initially when you're looking straight ahead in a static situation. So when we think about causes, number one, and that's why this is in larger font, it's because of vitreous degeneration, which is simply an aging change, and or detachment, which is separation of the vitreous from the anchoring here at the optic nerve. And again, to put things into perspective here, your optic nerve is about as big around as a pencil eraser. So you can think of it in that way. The infectious and inflammation causes here are secondary to serious problems inside the eye that may leave some residua, and in my case, were secondary to trauma. So, what are the concerns over the appearance of floaters? Well, number one, they can really be anxiety producing. And as you read through this, this is a lady who happened to find something about me on the internet. It was a publication that I did about flashes and floaters and retinal breaks and those sorts of things. And she wrote to me out of the blue from California. But I can also tell you that I had a patient once whose anxiety over her floaters were so bad that she was on prescription Valium. So can be pretty significant there. And as you take a look at this, you can see that this lady is 55 years of age. She saw these flashes in her right eye, and she had seen it before, and it was described to her as a migraine aura, and she suffers from those. And if you have that in your history, you're probably pretty familiar with what that looks like, the streaks and outline in your vision that doesn't really block your vision, but certainly interferes with things. And she said that this was a little different, but was only in one eye. So she was evaluated and had an explanation of this by an eye care professional. And the diagnosis was that this was secondary to posterior vitreous detachment. So when we had our little anatomy lesson there earlier, we saw how that might occur. And she was warned that if she saw a black curtain, I used to call it a curtain or a cloud or a shower of sparks or spots, that she should return for evaluation. And we'll talk about what that means anatomically, the significance of it, and we'll talk a little bit about the epidemiology. Fortunately, that is a very, very rare occurrence, but with very significant consequences. So when she was evaluated, her eye care provider would be looking through a dilated pupil here. You can see a little bit of the colored iris there. And then this is the vitreous that is now that clear plastic bag that surrounds the vitreous is now kind of crinkled. And that's one of the things that'll cast shadows and create floating spots. So she was seen on follow-up, and the retina specialist told her that this was a simple, uncomplicated vitreous detachment, and there was nothing alarming. In this case, she was not dilated, but her symptoms have lessened, and she only sees it occasionally. And that's typically what happens. I have a neighbor and a friend whom I see at the gym on occasion, and she recently experienced posterior vitreous detachment, and they don't really go away. The little floaters don't really go away, but you just get used to them and you tend to ignore them. So that's why she was seeing hers only occasionally in her peripheral vision. So her visual acuity is good, no complications with the retina or anything like that. And then she says that she rubbed her eye and she saw some extra floaters. And so she went back to the doctor, and again, they photographed her eye and assured her that everything was right. But you can see from her um, descriptions here that she really has a great deal of anxiety over this. And, hopefully we'll talk through this situation where posterior vitreous detachment causes this sudden appearance of flashes and floaters, and put things in your minds at ease. So now it's been 2 weeks, and she says she can blink and move them away. But again, as we think about this clear jello in a clear plastic bag with now some little spots in it, you can appreciate why that's moving around. But she is living in total terror. So this is the kind of anxiety producing uh, situations that posterior vitreous detachment can occur. And she's consulted Dr. Internet. So she's on high alert because she keeps reading different things. So what she wants to know is, can she do anything that might perturb this? She works on a computer. Can that be any problem? And if you have those same questions, I can put your minds at ease. Your eye is pretty tough. So just rubbing your eye a little bit is not going to disturb anything or make things any worse. And certainly reading or working on a computer all day is not going to be anything to worry about. She says the doctors have been helpful. They keep looking and taking a lot of pictures, but no one's really explaining this to me. And I think the big reason for that situation is that we as eye care providers tend to think of this as something that's, it's not much to worry about. It's sort of a meh. And for that reason, a lot of times we don't understand or appreciate what the patient's level of anxiety might be. And like I said, I had a patient who was so concerned over hers that she was on Valium. So a good explanation by your eye care provider, answering all the questions that you have is going to be very important to your understanding and hopefully giving you a nice, calm appreciation for exactly what's going on. So we saw this wrinkling earlier, and what we will see as doctors is this ring here. And I showed you the ring that I saw in my vision, and this is the ring that attaches the vitreous to the optic nerve, and when it comes through, that nice classic circular pattern is cast onto the retina. And as I tried to show you in my appreciation of that back on March 25th, 2009, exactly what that might look like. So if you experience a sudden onset of floating spots or to a lesser extent flashing lights, you will probably be dilated. Your pupil will be dilated to give the examiner a better look at things. To quote one of my mentors during training, it's easier to look into a room through the doorway than the keyhole. There may be documentation with a number of different uh, camera applications here. And you might be scheduled for a scan called optical coherence tomography. And don't worry about what this means. It's not going to be on the test, but that's just to look very closely. And I'll show you a couple of examples of what that looks like to make sure that there's nothing that is deep to the retina or any interface complications between the vitreous and the retina that is a potential for complication that might interfere with vision or create something called retinal detachment. So explanation after the evaluation is going to be very, very important. So let's talk about the consequences. And I'm going to call this the dark side. But what we should understand about this is that the dark side is a very small percentage, probably 5% of adverse consequences secondary to posterior vitreous detachment. Now, while the consequences can be serious, understand that they are very, 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 very unlikely and only occur in about 5% of situations. So one of the objectives of that dilated exam is to rule out these significant complications. And that's going to be some sort of a retinal break, which means a tear in the retina, and that can result in or lead to retinal detachment, or if there is any blood, which would come from a broken blood vessel. So this is going to be a bright light. And then, as I mentioned, there might be some additional imaging studies if, for example, you have a cataract that is obscuring vision, or if there is something that to the examiner says, wow, I really want to see things a little better just to make sure that everything is okay. And as I mentioned, the complications are very, very rare. So the majority of these, about 95%, are uncomplicated. We're going to see from a couple of recent studies that kind of very much holds true. One study from Wills Eye Hospital in Philadelphia and another one from the West Coast. Now, all that said, only about half of patients who have an acute onset are symptomatic. So the other half are asymptomatic. And I can't tell you how many patients I've seen who have an acute onset in one eye. And when we do the examination, we see that that's already happened in the fellow eye. But patients will swear up and down that they never noticed anything like this in the first eye. So that's something to understand, that there can be kind of a dichotomy between what patients see, experience with regard to the onset of a floater secondary to posterior vitreous detachment. And you're probably going to be asked to come back within 6 weeks. Now, if you remember back to the patient who wrote me from California, she was seen on follow-up in a week, in 2 weeks, and there might have been a little more going on that she was not relating to that prompted those shorter intervals of examination here. So as I mentioned, there's a pretty low likelihood of complications. And this is a study from the Wills Eye Hospital. And if you're familiar with Philadelphia, this is kind of the icon of East Coast eye care, Bascom Palmer and um, Johns Hopkins being a couple of others. But what they looked at was the charts from 8,000 eyes who were evaluated for this acute posterior vitreous detachment. And they found that 16% showed a retinal break. And that's a little higher number than we talked about in terms of complication, but you have to understand that this is a tertiary referral center and not just your run-of-the-mill primary eye care. And about 6.2% showed retinal detachment. Now, retinal detachment is very, very significant. My great uncle, who was part of a household that I grew up in, had suffered retinal detachment in both eyes. And that was secondary to cataract surgery back in the 40s. That was not as sophisticated as it is today. And unfortunately, he lost vision in both eyes. So, retinal detachment, fairly significant. But we see this time interval of about 6 weeks that the delayed breaks occurred within about 6 weeks of presentation. So, what that reminds us is that when you have this sort of situation, a posterior vitreous detachment, you're going to be asked to attend for follow-up, perhaps at a pretty short interval after the initial evaluation. Now, back to the rarity of this. Retinal breaks and detachments occurred in only about less than 3% of either a retinal break or a retinal detachment on presentation. Now, another study, fairly similar numbers here, 8,300 who were part of the Kaiser Permanente healthcare system. They were looking for risk factors for retinal tear or retinal detachment among symptomatic patients over the course of a number of years. And these are their results. Either rhegmatogenous, which means retinal tear detachment, occurred in about 4% of patients and retinal tear in about 4.5%. So what was significant in this study was that they looked for symptoms, okay? Blurred vision, number one. And I happened to be expert witness on a case where a patient presented with some floating spots, was seen and it was kind of dismissed and follow-up wasn't scheduled. And he came back in because he was a law professor at Fordham University and needed his vision and noticed blurred vision in that eye and was found to have a retinal detachment within about 2 weeks of his initial presentation, which would be consistent with the next two elements of risk, being male and age greater than 60. If you're nearsighted or myopic, this age ceiling might be lowered just a bit. Other risk factors were prior keratorefractive surgery or prior cataract surgery. And then in this particular study, they found that flashes and floaters were only mildly predictive of these consequences of rhegmatogenous retinal detachment or retinal tear. So significant there with regard to symptoms. And in this study, at least blurred vision stood out. So if you experience flashes and floaters and you're scheduled for a 6 week return, but experience blurred vision, maybe you should go back sooner. Some of the other potential adverse consequences can occur with this 5% roughly. And you saw it was about 4.5 to 6.2%. So for sake of a round number, 5% is what I like to use. That can result in distorted vision, which is called an epiretinal membrane. It goes by some other names, but this is probably the best clinical descriptor, or vitreomacular traction. And what we're looking at here is an eye that has relatively clear media, so we can see the vasculature. This little area right here is the macula, as in Macular Degeneration Association. And then this irregularity here and a little bit of opacity is where the vitreous has not separated cleanly from the retina and is causing some complications. How many times have you tried to peel a label off an envelope and it sticks or it tears? And that's what happens inside the eye when there's some residual or continued traction right at the macula. So here's our optic nerve. There's our ring that has separated cleanly but can still cast a shadow onto the retina. And this traction, you can imagine pulling with this big mass of clear jello in a clear plastic bag that might result in a tear of the retina or some other complication with residual attachment. Let's look at a case example. This is a patient whom we evaluated, a 60 white female who has really nothing significant in her history, has relatively good visual acuity, 20/25 here in the right eye, 20/20 in the left. The intraocular pressure was normal, and all of her externals were unremarkable for age. She has not had cataract surgery, so she is phakic. And we're looking here at a view of what we call the posterior pole. And we can see the view here is very good, so the media are clear. Here's our optic nerve, which has very distinct margins to it. The retinal vasculature here is very normal. And our macula at first glance appears to be relatively unperturbed. But remember, the acuity is not at standard, not at 20/20. And when we do this optical coherence tomography scan, what we see is here's our retinal vasculature. We're taking a look at this one center cut through the macula here. And we can see that there appears to be some proliferation. We would expect this to be a nice smooth area here with just this, with a little dip here. And then we see this proliferation on the surface. But what we also can appreciate from this clinically is that the outer part of the retina, the rods and cones, if you will, are all very nicely aligned, and all of the retinal laminations here are in very good shape. And that's consistent with her 20/25 visual acuity. So really, there's not much to do here except to follow this patient to assure that there are no complications. And we can see, if we look up here, this looks uniform and dark. So keep this in mind as we look at the next case, that there's no attachment between vitreous and retina, as we saw in the schematic here, that would be consistent with trying to cleanly peel a label off of an envelope. So, little levity here from a Lowe's ad that takes the guesswork out of storing bodies. Hope you all appreciate the morbid humor there. So this is a patient who's a little bit younger than the previous one, a 51-year-old who complains of distorted vision. And remember, blurred vision is very, very significant with regard to potential for significant consequences following posterior vitreous detachment. So she claims that this has been going on for 3 days. And as an eye care provider, I can tell you that when a patient tells me that it's 3 days, it's probably been closer to a week. Acuity is reduced, so we're looking at 20/60 here. And just to put this in perspective, what this means is that a patient with 20/20 vision can see at 60 feet what a patient with 20/60 vision would have to be at 20 feet to see. So it has to be much closer. Nothing significant in her history. And this is what her right eye, if you follow this seam here, we're looking at right eye here and left eye here. So our media look very clear, which gives us a very good view of the posterior pole. The disc margins are very sharp. In each eye, the retinal vasculature appears to be very much intact. There's no leaking. There seems to be a little bit of disturbance, and it's very, very subtle here in that right eye. This is the one with the poorer vision compared with what we're seeing here in the left eye. So if we do a scan here, what we're seeing is that there is some continued attachment by the vitreous at the macula, which is creating these cystic spaces and distorting the laminations of the macula. So think about this as the label that I'm trying to pull off the envelope, and then what's happening at the level of the envelope there, where there's some additional attachment. So we can look at this in a horizontal scan and a vertical scan and see a pretty much similar picture, but it gives us an idea of the extent of that. And we can see that that is greatly diminished as we look at some of the other scans here. Now, the fellow eye is a little different story. And this is what we would expect a normal macula and fovea to look like. Nice, smooth margins, normal retinal layers here, nice regular laminations, but there's some residual vitreous attachment. Now, it's not created the havoc in the left eye that it did in the right eye, but this is the eye with the better vision. And in many cases, the situation in that left eye is going to take nature's course and resolve on its own. And we'll talk about what that looks like and what some of the remedies might be in this particular case where we have reduced vision. So let's take a look at this clinical trial that was first published back in 2012. You can see that these floating spots here look somewhat similar to the picture that I took through my windshield driving to at Atlanta. And then what this vitreous would look like to the clinician. And what this clinical trial involved was to try and dissolve these vitreous opacities with an injection into the eye with something called aquaplasma. And what I'm going to show you here is the results of this study. And what they had was two groups. And what I'm going to ask you to draw your attention to is, first of all, the y-axis. And this is the percentage of patients with resolution. And we can see that it goes up from 0 to 10 through 15 to 20 to 25. And pay attention to the solid line here of the black portion of this, which was the patients who received the injection, and this blue line, which was the group that was followed. So those are the ones who had spontaneous resolution. And we can see that we had about half as many resolve on their own as resolved with the injection into the eye. But that took place at about the same time point. So our x-axis here is typically time. So we're looking at about a month here, and then 3 months here, and then all the way out to 2 years here. And what we see is, 90 days, and then 180 days, six months. But what we can see is a similar shape to that curve, suggesting that spontaneous resolution can occur in about a month. So if your eye care provider is asking you to follow up within 6 weeks, within 4 weeks, within 1 week, 2 weeks, it's because of the results of this clinical trial that compared those who had spontaneous resolution secondary to no intervention and resolution secondary to the medication that was applied. So, who's the best candidate for this? And this is something that's been around for quite a while, and it's fallen out of favor. But in the interval when it was first introduced and cleared by the FDA or approved by the FDA, there's been kind of a refinement as to who might be the best candidate for an intravitreal injection. And that looks something like this. Patients who have not had cataract surgery, patients who are older, over the age of 65, Medicare eligible, if you will, no previous surgeries, no diabetic retinopathy, and no macular involvement. So these are kind of the confines for who might be the best candidate of this injection into the eye, which is not without its side effects and consequences as well. But more recently, one of my former colleagues, Dr. Morris, at the Eye Foundation Hospital in Birmingham, Alabama, next door to the building that I used to practice in, has developed this vitreous opacity vitrectomy. And he bills this as the safest possible removal of vitreous floaters. And having experienced vitreous floaters for probably close to 50 years, and looking at what the different treatments have been and how that's evolved over the course of years, this is the one that seems most effective and something that, if it becomes much more obstructive to my vision, I would consider doing. Now, there's a scan code here that you can look at because you'll have access to these. But the results look something like this. This was a series of 81 patients. And as we saw with the injection into the eye of a medicine, were over the age of 65. And this is a procedure that was done with a 27 gauge vitrectomy probe. Now, look at this 27 gauge. A 27 gauge needle is about what you get your flu shot with, what you get your tetanus shot with, what you get your COVID shot with. So this is a very, very fine needle. And this used to be done at surgery with much coarser needles and with not as good outcome. But these patients all had symptomatic opacities that were interfering with their activities of daily living. So they all achieved clearer vision, no complications at 1 year. The patients who had not had cataract surgery did develop a cataract, and there were only 3 retinal breaks observed that were treated. So this, to me, now that we're up to 2022, seems to be something that is very, very significant for those of us who have symptomatic floaters that interfere with our activities of daily living. And I can tell you that mine interfere with me most significantly when I'm reading, when I'm looking at a screen, as I am doing right at this very moment. So we've talked about kind of the dark side of consequences and how patients can develop distorted vision secondary to vitreomacular traction or vitreomacular adherence, the possibility, the very small possibility of a retinal break or retinal detachment. Situations or consequences that are remediatable. Okay, there are surgical options to close retinal breaks, to prevent retinal detachments, and unlike my great uncle, not suffer those significant consequences of intractable retinal detachment and proliferation and consequently loss of vision. So if you've suffered posterior vitreous detachment and you happen to be a patient with diabetes, it may lower the risk for diabetic macular edema. And if you are a patient with diabetes and have any level of diabetic retinopathy, you're probably familiar with the term diabetic macular edema. And also, since we are here at the Macular Degeneration Association, once PVD has occurred, it might lower your risk for progression to wet AMD or the progression of dry age-related macular degeneration. And you can see that some of these studies now are several years old, but they seem to be sustained with contemporary literature as well. So you might say, well, gee whiz, if I have floaters, somebody's going to want to stick a needle in my eye. or somebody's going to want to do a surgical procedure that is a vitrectomy. And that surgery, by the way, is done in office. You're not taken to the operating room. It's done in office. Maybe that's not something that I want to do. And there is the possibility of laser vitrectomy. And if you've looked or laser vitreolysis, that's probably something you've seen on the internet. That's kind of fallen out of favor. But there is a specific antioxidant oral supplement that might be significant or useful for reducing um, vitreous floaters. So that's shown here. You can see the constituents if you blow this up, or if you look for it on the internet, there's a link to that from the folks at Macular Health, one of our sponsors here today. And this might be an avenue that you can try if you have floaters that are interfering with your daily activities of daily vision, daily living, and you're not someone who is amenable to surgery, maybe not a good candidate, or maybe just fearful of any sort of surgical approach, as I have been over the last 50 years with my floaters. So, in the absence of complications, there is the surgical procedure of vitrectomy, which seems to be very, very significant. Laser vitreolysis, which, like I said, has kind of fallen out of favor. One of the first trials that was done on that was a study that was done in France, and they abandoned the trial very early because what they discovered was that making little ones out of big ones was much more disturbing to patients than their original condition. And then the pharmacological vitreolysis, as we mentioned, that's been around for over a decade, that might be appropriate based on your particular situation and a recommendation from a retina specialist. So with that, I will open the floor up to questions. Say a big thank you to the folks at Macular Degeneration Association for having me, and a big thank you to you in the audience. Okay, question is, why does cataract surgery affect some treatments? And this is pretty rare. Cataract surgery today, and I've had cataract surgery in both eyes, and I've seen dozens, hundreds of patients who have had cataract surgery, and there's really very little disruption to the eye, to any other part of the eye, other than that little M&M candy that is being addressed in cataract surgery. But there can be complications when the procedure takes longer than normal because the lens is particularly difficult to emulsify and remove from the eye. So prolonged procedures from cataract surgery can disrupt the inside of the eye, but that's very, very unlikely, except in the case of pre-existing conditions like diabetic retinopathy or like having a pre-existing retinal break.
In your experience, is there any reason to hold off on cataract surgery?
No, in fact, my first cataract surgery, I put off for about a couple of years, and the day of, my wife took me home, and I said, "Honey, I should have done this 2 years ago."
Looks like we
Okay,
got another question coming in.
can a prior retinal tear be a precursor for age-related macular degeneration? And retinal tears typically occur in the periphery of the retina and typically do not have any relationship to what's going on in the center of the macula. So a prior retinal tear, if it's been repaired, is typically not any increased risk for developing age-related macular degeneration. Okay, does optic nerve drusen have any bearing on floaters? Short answer is no. So optic nerve drusen is going to affect the optic nerve specifically, and the vitreous is not attached anywhere except around the periphery of the optic nerve. So you're not going to have any cross-contamination there, shall we say, between optic nerve drusen and vitreous floaters.
Thank you so much, Dr. Sims. We want to remind everyone that this was a recorded webinar, so we will go ahead and get this up on our website shortly. So that if you want to watch it again, it is available for you. Otherwise, we hope you had a wonderful time here today and got some information that helps you on your eye journey. And Dr. Sims, we want to thank you again for joining us. And everyone, we want to encourage you to come back for the next webinar, which I believe will be the final one of the year. But we'll obviously look forward to continuing these into the future. So keep checking back to macularhope.org, and we will continue to provide you with the latest information about many different eye diseases and symptoms or conditions. Thank you so much, Dr. Sims, and everyone have a wonderful day.